Brandon and James here, or should I say Dr. Hodges and Dr. Mansfield. PG, yeah, yeah, yeah.
Yeah.
I'm so sorry I called y'all by your first names. Please forgive me. But yeah, so we have some prepared questions that will kind of for both Brandon and James. But also feel free, anything pops up, drop it in the chat. Actually, I would just be interested if you just put in the chat like what year you are. I think that'll maybe kind of help us a little bit when it comes to like just providing advice. But yeah, that's it. I'm not that. Brandon and James are the ones who pulled this off successfully, so they're the ones you're really gonna want to listen to. But yeah, Brandon, would you be able to? Yeah, you wanna continue on?
Yeah. So I'm Brandon, currently an intern here at the University of Virginia, matched in a categorical position, meaning that I'm doing my intern year as well as my PGY2 through PGY4 years here. Um, and yeah, so don't really have a whole lot of exposure to the PM&R department this year. We're limited to a month per like the ACGME requirements. But more than happy to be here tonight. Really thankful to be invited to this, and yeah, happy to answer the questions that you'll have tonight.
Sweet. Thank you, Brandon, James.
Hey everyone, I'm James. I'm also a PGY1. I'm matched up in Metro Health slash Case Western here in Cleveland, Ohio. So the weather's finally starting to get a little chillier. Unfortunately, not a big fan. But it's yeah, so I'm from the Chicago suburbs. I kind of knew about PM&R a little bit before I went to medical school, and then throughout medical school, got a little more information. My program's also categorical, so I'm doing all 4 years here at the Metro Health System up here in Cleveland. But yes, just like Brandon says, mostly doing internal medicine this year, and I get 1 month of PM&R inpatient before I move on to the more PM&R centric years.
Great. Yeah, no, thank you. I think starting off, I think it'd be good just to kind of talk a little bit about how y'all became interested in the field of PM&R. I think James is pretty unique coming into MCG. I think he was probably the first person in our class to know the field of PM&R existed. Brandon also had some early interest too, so I myself was probably a little bit later down the line. So I think it'd be good just to kind of hear how y'all get interested in the field and kind of what drew you to it.
Yeah, I can start. So I didn't go to medical school the traditional route. I actually was an engineering student in undergrad, and then I actually worked in the business sector for a few years in software business consulting and then data analytics at a plumbing company. And then really during that time, I was actually considering going into healthcare long term because I was wanting to work with people in a more personally meaningful way for me. And I actually thought about physical therapy school for a while, but then my interest grew more into medicine because I also wanted to keep my doors open. I like the diagnosis and medical management of things. And then because I looked at PT school first, I knew about physical medicine and rehab was kind of adjacent. You don't really do the same thing, but you're focused a lot on the function of people, the quality of life. And so I thought that was a really cool vision that the specialty has that made me learn more about it once I started medical school. And then I just kind of took some time to shadow some of the PM&R physicians who are in the Augusta area, and that's kind of where my interest continued to grow.
Yeah, I'd say for me, back I went to UGA for undergrad and got a biology and exercise and sports science double major, so was exposed to a lot of people inclined pursuing more like physical therapy. And didn't really know what PM&R was until my second year at MCG. I took this medical specialty quiz. I think it may have been on the AAMC website, and ortho and PM&R were the two specialties that were at the top. And I never heard of PM&R, so I did some more digging into it and saw that it offered a lot of the things that I value. Obviously, I really enjoy kind of kinesiology, just the study of movement and function and quality of life, and really enjoy having intentional patient interactions. And as I started to kind of do what James did by, you know, shadowing some physicians in Augusta who did PM&R, I felt like my most meaningful interactions were with patients who were at the acute rehab hospital or who were in sports med clinic, and I felt like I could relate to them really well. So just continue to go down that avenue. The cool thing about PM&R is you can do a lot of inpatient PM&R, or you can go into a fellowship to do other things that we can talk about later. And so I wanted to be able to use my hands, but I also just didn't really like the environment of the OR as much. And so I think that's why PM&R just really encompassed a lot of my interests.
That was great. Thank you, Brandon. Yeah, no, I think that was something too. I think just starting off too is like kind of what is PM&R? I know some of y'all a little bit earlier on in your medical training, and if you're a little bit later on and still wondering, it's okay. One thing I think if you decide to pursue this field, it's a question you're going to get asked a lot, pretty much from everybody you know that you come across. So it's just, I think part of choosing this specialty is be ready to explain it to pretty much everybody you meet. So yeah, yeah, and I think Brandon and James both both kind of alluded to like kind of what the field is in itself. But I think if like the best way I can describe it, and everyone's kind of got a different way going about it, it's like you develop like an expertise in like neuromusculoskeletal medicine. And you use that expertise to help restore function. And that function, restoring function, that could be in the inpatient realm, outpatient realm. That could be working with individuals after spinal cord injuries, traumatic brain injuries, strokes, major traumas. And those are usually a little bit more kind of the inpatient's route. And on the outpatient side, too, again, restoring function could apply to that in sports medicine, pain medicine, interventional spine. The field I think about PM&R is really cool is the more I've learned about the field, the more I really like the more opportunities that I've realized there are. There's so many different ways you can go with this field, which I think is a huge beneficial aspect to it. And you don't have to have it figured out now what you want to do, but it's good to go into the open mind and just kind of understand what the field kind of consists of. Because when it comes later down to interviews and stuff too, just having a general idea that you know of kind of what the field is important, and it's something you'll get asked on the interview trail. So, um,
Yeah.
anything, Brandon, James, like you want to add to that?
Yeah, I mean, I like how you kind of described it. I think because it's so versatile and especially different from outpatient to inpatient, I think a lot of times people get really caught up with the neuromusculoskeletal part of it, which is certainly a big part of it. But I think I didn't really understand the inpatient side for a long time until I did rotations and aways. And really, how I like to break it down is if you're an inpatient physiatrist, or inpatient PM&R physician, a lot of it is you're kind of like internal medicine for the patient while they're getting rehab, but they're a little more stable than an acute internal medicine doctor's patients would be. So a lot of times you're just managing their chronic issues, make sure their pain, bowel, bladder function, sleep, and cognitive things are going okay so they can get the most out of their 3 hours of mandated inpatient therapy every single day, on the weekdays at least. So I kind of like to think of it in two different ways. Like yes, you do have to know the neuromusculoskeletal stuff. You're not really doing any of that on the inpatient side to actually help them get better. That's the PT and the OTs doing that, and the STs. But then on the outpatient side, you might be applying that a lot more for like treatments, procedures, all that other stuff.
Yeah, no, I think you guys both summed that up pretty well. I don't think I have anything else to add.
Yeah, no, James, I think great job with the inpatient side because I think that's something the more experience I've gotten, especially on away rotations, you're right. On the inpatients, I mean, that's probably the best way of saying it is you are kind of like the almost kind of like the hospitalist for, and you usually actually end up working with the hospitalist for the more internal medicine side focused side of things. But yeah, as James said, kind of like optimizing your patients medical side of things, especially with kind of the things that you're trained in, which is or sleep, appetite, managing bowel bladder, pain, so they can get the most. Again, the ones that are actually doing a lot of the hands-on stuff in the inpatient side is the therapist teams that you work with. So yeah, thank you for adding that because I think that is pretty essential and to yeah, knowing what the field consists of. So I got some more questions here. Happy to go with them. But if y'all have any questions too along the way, feel free to drop them in the chat. Um, and we will definitely get to them. But I think one question I think I wanted to ask were just for both Brand James, like what were some experiences that you found, I think, most useful during your time in medical school and that you found yourself talking about when it came to interviews that you really think like yeah maybe helped you stand out or and not only just stand out but were kind of important to like kind of your story in your route to PM&R.
Yeah, were you wanting this to be more specifically for medical school experiences?
Yeah, yeah,
Yeah.
more medical school.
Yeah.
Yeah.
Absolutely. I think I think the biggest experience for me that was brought up a lot for interviews was my week at a summer camp called Camp TBI. Um, it is in Rutledge, Georgia. It's put on through the Walton Foundation. Um, so they're associated with the Encompass in Augusta. And so kids who were either born or had acquired traumatic brain injuries, it's a week where they get to go and experience a traditional summer camp where they have adaptive setups for several types of camp activities. And you really get up and close with the kids as well as occupational therapy students from Augusta University. And it's just very eye-opening, and you really get to see what a day in the life of one of those kids is like. Um, and that's something that is open to all of you during the summer months. I don't know when they'll have it at this upcoming year, but it was something I think was very valuable as an experience.
Yeah, for me, given that we didn't have a whole ton of local opportunities, I would say one of my most significant medical school ones, I think, was when I actually applied for a role on the Association of Academic Physiatrists Medical Student Council. So that's the AAP is one of the PM&R national organizations, along with the AAPM&R, which is the American Association of PM&R. And so sometimes there's opportunities to apply for national council leadership positions where you can you can really make a difference in the type of roles they offer. But also, I think it's a really cool opportunity to meet other students who are from different programs that might have residencies in PM&R. Or even if they don't, you at least get to meet people who are also passionate about the field, kind of start building your network. Because this is a very small specialty. And honestly, like these people you start meeting are probably going to be your future colleagues in a lot of ways many years down the road if you choose to go down this specialty route. So I would say that that kind of opportunity was probably one of the most meaningful for me in medical school, PM&R wise. And I guess specifically, what I did on it was I was on the outreach and membership committee. So I helped with like connecting a lot of different interest groups to the national organization and finding ways we could support different interest groups.
Yeah, no, thank you guys. I think those are both two different great opportunities. And that's the coolest thing about PM&R too is like there's a lot of different things you can get involved in that can relate to the field, whether that's working with individuals with disabilities, getting involved on some of the leadership councils. I mean, doing some work in sports medicine, doing some work, there's like work in neurology. There's a lot of different fields that kind of apply to PM&R. So you can kind of, when it comes time to crafting your story, I think the most important thing is one, like get involved in things that you like, make sure you enjoy it, too, because I feel like they can tell if you don't. But a couple things I want to touch on based on what they just said. One, I think Brandon talking about when it comes to, preparing your application, having experience working with individuals with disabilities is massive. And the camp that he mentioned is a great opportunity. There's a lot others like it. And also even just in Augusta itself, another organization is called Wrecking Crew. I'm not sure, maybe y'all are familiar with it, but it's just in North Augusta. It's a group for individuals with intellectual and physical disabilities, and it provides them an opportunity for like recreational activities, basketball. I know I think they just finished building or have built a like new kind of field out there as well for kind of like adaptive baseball. There's now an adaptive sports group called Catalyst Sports. This is another opportunity in Augusta. They do things like biking, rock climbing, I believe kayaking as well. Another great chance, just again to kind of, yeah, show that you've had experience working with those with disabilities, because that is a big part of what PM&R is all about. It's like kind of, yeah, advocating for those disabilities and having experience, yeah, working with them. So look for opportunities like that. Those are a couple on my mind. After this, I'll send more opportunities. Um, we got an upgrade. Let's go. We'll have more opportunities. I'll send a list of some. I want to talk more now about what James mentioned. So yeah, there's two major national societies. One is AAP. The other one is AAPM&R. When you type in AAP, add in physiology. AAP also the same one for the pediatrics organization. That one has a few more members, so it might be the first hit. But AAP is kind of more the academic side of PM&R. So it's going to be a lot of, yeah, like academic programs, ones that have residencies. AAPM&R is going to be for both kind of academic and community physicians. So both of these organizations, they have leadership opportunities. The council James is talking about is actually currently has applications open. It is open right now, so I will send out that information to you. I recommend following both of those organizations on social media, especially AAP, AAPM&R. There's another one called Pathways in PM&R, which isn't necessarily one of the official, membership groups, but it's a really good one too for additional leadership experience. So I think something like look, going back, if I could do something, it probably would have gotten some leadership experience in PM&R. And as James touched on, PM&R, it is a really small field. I did one rotation with one guy. I have proceeded to have that same guy and these are interviews with maybe like 4 to 6 people. He's been in three of my other interviews. I did a transitional year interview, which I think Brandon James touched on. So there's categorical programs, which are it's 4 years. That first year is you're only going to have about a month of PM&R, but you do it at the same location. And then there's programs that are advanced where that first year you're responsible for either finding a transitional year or a preliminary year like in internal medicine, or if you're, I don't know I mean, you can do an you can do a surgical year if you'd want, but that'd be pretty wild to go that route. Please don't do that. But if that's your thing, go for it. But anyways, just touching back, like, so I've seen this. I saw even in a transitional year interview, which had like dermatology, anesthesiology, radiology. He was there. It's like you will find that. Yeah, I think it's a very small field, so networking is really important. And those organizations, AAP and APM&R, have great opportunities when it comes to those what's the right word? Committees. And then also. I can talk more about this later too, but they also have national conferences, which are great opportunities to present research. And that research, there's so many different areas in PM&R, like you don't have to necessarily have done research with the physiatrist to present at those. I've had the chance to present at the conferences, and they were just doing two different projects that, yeah, didn't have a physiatrist on board. So, but they're really good opportunities. And I can talk more about them later, but just want you to know they're out there because I didn't learn about them until later on. Um, but yeah. So I went on a little tangent there. Anything, yeah, about that, Sam, Brandon, James?
Yeah, I was actually going to jump in. So, all right, so we're good on the meeting, and now I'll jump back in. You brought up research. I wanted to ask, James, Dr. Mansfield, Brandon, Dr. Hodges. So, did you guys have any PM&R related research when applying or anything, related to the specialty that you guys think would be helpful to have on a resume when applying to this field?
Yeah, you know, definitely did some research. I did not do anything specifically associated with PM&R. I found that that was difficult, being when I was in Augusta, and then I went to the Savannah regional campus. Like it wasn't it was a 3-year campus at that point. Not 3 years. Like you started in third year and do fourth year there too. So it's pretty tough to get on something. So really, I just kind of hopped on whatever I could get my hands on. And the beauty of PM&R is that it really does encompass different qualities from different specialties. So, if you were to, I found something with family medicine, with neurology, and yeah, did a few things like within those domains, and it transferred over nicely. So really, like, it doesn't matter fully like kind of what you do. It's nice if you can have something PM&R related, but if you can do something that's of quality and can talk about it well during your interview and show that you contributed, what you did, showed initiative, showed interest, that also goes a long way. And, when you talk about yourself in your interview, they know if you do or don't come from a home program that has a PM&R residency. And so they're not gonna automatically think less of you for that. They just want to see mostly initiative. But something from PM&R is a nice cherry on top, but it's not required per se.
Yeah, the field of PM&R in general, we're not really one of the best specialties to have really heavy duty research to begin with. We're not cardiology or neurology. And that's something that is kind of honestly a bit of a flaw sometimes because you have all these treatments nowadays, like PRP and other stuff that really needs a little more investigation in terms of evidence-based medicine. But in terms of the research I might have had, I didn't do too much in medical school. And like Brandon, we don't have a department, so it's nearly impossible to find anything very specific unless you're that rare lucky person who finds like a really good case to write up potentially. But I just kind of joined a project that was involved with more like low back pain and kind of data analysis related to that. And so what Brandon says is really true. Like because our field is not, we don't own just one organ system, but we touch on a lot of different ones. You can really translate a lot of different research to rehab. So let's say you got onto a urology research project related to some sort of bladder function. You could tie that into PM&R because that's a huge thing. Everyone who has like a stroke, spinal cord injury, a brain injury will almost undoubtedly have some bowel or bladder dysfunction. Or you could do neuro, you could do family medicine, like you said, sports medicine. You could even do you could even do cardiology stuff because there are some things that we study in PM&R that in a patient who's had like amputations, for example, their cardiovascular system has to work a lot harder. That's a little more niche, I would say. It's not the research everyone would think of at first when you talk about PM&R. But I just bring these examples up because you can tie, if you're creative enough, you can really show how your research ties in the PM&R with the functional improvement, quality of life. And also, if you're able to explain how it kind of impacted you and how it kind of broadened your mindset, that's also helpful in the interviews. It doesn't have to be directly related to the PM&R, but if you can show how it was meaningful, that's really all they care about. As long as you're genuine about it. If you fake stuff, people sniff that out really quickly.
Yeah, thanks for bringing it up. It's definitely some great points in there. I guess to kind of just keep adding on to, research, applying to, would you guys say PM&R these days is a competitive specialty to get into or, increasing in competitiveness? I just kind of wanted to see y'all's opinions on that.
I don't know. What do you think, Brandon?
Yeah, I think, yeah, long story short, I'd say PM&R is becoming a more competitive specialty. The match rate is about the level of anesthesia, if not like 1% tougher. And I think it really solely just is based on the fact that there's not a ton of PM&R programs around the country. I don't know the number off my head. It's like 100 and
100. Yeah.
hundred, like low hundreds. And so programs can have anywhere from two, to six, maybe eight residents per program. So just from the limited number of slots there and the increase in the amount of people being exposed to PM&R, that just kind of creates a bottleneck. So yeah, I'd say it's getting more competitive, but it's still something that is very attainable. If you're doing the kind of things that we talk about and show initiative and kind of do what you're supposed to do from the academic side of things, can absolutely be a competitive applicant no matter where you end up applying to.
Yeah, no, that's a good point. Yeah, especially the statistics. I would say like we're not like derm or those specialties, but we're more in the middle nowadays. It used to be decades ago, all you needed was really just a pulse to match it. And we were literally ortho's backup. But now, they get a little upset if they sniff that out too much because the truth is we're not really like orthopedics. Like I don't think someone who's really interested in surgery and ortho would be very happy with PM&R, honestly, because of it's not all just like neuromusculoskeletal. There's a lot of other facets. I would say that we're more competitive in the sense that there's more people showing genuine interest in their extracurriculars, leadership, research, and other things, and volunteering. And so it used to be that just running an interest group was probably good enough to get interviews. Nowadays, you probably have to do a little bit more to demonstrate you actually know what the field is and you're interested in it. Yeah, because I think it's this field does actually have a pretty high rate of burnout, ironically enough, if you look at the statistics. And I think a lot of it is sometimes people have a very different idea of what this specialty entails from what it actually is. And so that's why I kind of harp on my definition with the inpatient rehab, because I think everyone keeps thinking of just the outpatient stuff. But you have to do 12 months of inpatient rehab in residency. And that is honestly where the field came from originally. So even if you don't want to do that fully, I think you need to have some understanding of what you're signing up for if you go into this field.
Cool. And I just want to ask this question to just put this out there. So, I guess what is the match process like? Like, are you applying directly to PMR? And then also on top of that, how long is the residency?
Since I'm going through that right now, I feel like I'm pretty steady up on it. So the application process, yeah, so we talked a little bit about, there's categorical programs where you only have to apply to that program, and you don't have to apply to additional transitional year or preliminary year. Then there's advanced programs, and it gets confusing because some advanced programs they also have transitional year programs, or sorry, they have transitional year programs there too. So it can get a little messy, but like the application process in itself too has changed a lot because if y'all earlier on, I didn't. They've created this thing called signals for matching. Some of y'all might be familiar, especially if you're a little bit closer to the process of applying. But they went from Brandon's and James' class. You got 8 signals. So these are ways to, when you apply to a program, you can attach a signal to them. And that's supposed to show that you have extra interest in that program. And some programs will use that. Um, well, it's changed a little bit because when it used to be just 8, it was 8 for them. Now it's 20. So now that it's 20, some schools are using them pretty much just to filter down applications to their signaled individuals, especially ones that are competitive and are receiving a lot of applications because it's a pretty easy way to kind of narrow down those who are really interested in your program. So that's something I think that's kind of changing. We don't really know the stats yet of how many interviews or what's the percentage of interviews you get outside of the places you signaled. So when it comes to like when you're applying, it's good to kind of have a good idea of yeah, the kind of the programs you're interested in. And the I kind of want to backtrack a little bit because I think now one of the most important things for when it comes to matching are going to be, especially coming from a place without a home program, is away rotations. Away rotations are by far, I think, the best way you can increase your chances of matching at a particular location. Um, so away rotations, that application process will start in January, February. I can go more into detail to this, especially for those that are about to go through it. And I have a couple like resources that go have good information, but you want to be on the earlier side. You want to know what places you're interested in going to because you really want to go to a place. You want to make sure you do an away there. And right now, without a home program, the recommendation I got was 2 to 3. Now without a home program, I would say 3 for sure if you can. And if you have the room for it in your schedule, a fourth can't hurt. It's just when you comes if it's, and this is kind of a newer opinion I'm having just based on the individuals I've talked with kind of through the application process this year. But not that every place gives interviews out to those places you do aways, but it's pretty rare to find a place that doesn't give you an interview if you do an away there. And it's a really good chance to also get a sense of a program. Is it good a fit? Is it not? And also when it comes to getting red letters or rec, this is something too. You'll have chances. There is the Augusta, there are a couple Augusta positions you can rotate during that rotation, but getting the letter rec from someone at an academic program, I think is very important, especially you can get one on the inpatient side. James has kind of alluded to, it's very important to kind of show a lot of these program directors, excuse me, and a lot of them are run by individuals who are on the inpatient side. So if all they see on your application is outpatient, 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 then they might not be as interested, yeah, in your application. And there are some places that are very much MSK procedural focused, but a lot of programs, there's going to be people running those programs when it comes to doing interviews that are on the inpatient side. So, yeah, I don't know if Brandon, James, you want to kind of add on to that. Those are just some kind of general thoughts I have about the application process is going through it. But it's just been tough. It's a tough year because with the 20, I think people are getting maybe a little bit less interviews than they've had in the
Hmm.
past because the 20s kind of created almost a kind of a cap in a
Yeah.
sense on the interview invites. While in the past with 8, you can kind of signal it's like, okay, if we're not in their top 8, then we could maybe they'll move up. We can convince them to come here and they can match here. But if you're not, if a program doesn't think you're in the top 20, it really I think decreases their interest in you and your chances of ending up there.
Yeah, no, those are really good points, Michael, especially because you're in the thick of it now. Because when we applied, you're right, it was 8 signals, totally different ball game. I think 3 aways are probably really important. And I will say, like, the caveat, like, since a lot of these are in your first year, you kind of have to pay for all of this, unfortunately. So whether that's loans or other savings you have, usually you have to kind of shell out the money to go do these aways. Like I did one in Boston, I did one in New York. I got really lucky in Boston. I had a friend, so I was able to only spend like 1,000 for the month. But some of these places you have to do housing, you have to do transport, and then on top of it all, you have to like try to be on your best behavior at work under away rotation, and so it really can be stressful. But yeah, I think what you said is great. I think do 3 aways is a good target at least. I think 4 might be good too if you can afford it. Um, but I think nowadays, like most people likely probably match where they did an away rotation nowadays, except for me. I didn't really like the programs I rotated at, so I ranked them lower. So I actually didn't rotate here in Cleveland, but the ones I rotated at, I actually ranked below this place. But I think for most people, you rotate at a place, you get a good feel, and then they like you, you like them, and then you're able to get a better chance of matching there. Um, that whole ramble was basically to say, like, yes, I agree with what Michael says.
Yeah, no, I agree with what these two fine gentlemen have said. One thing I will add though, you do, I don't think this has changed. You get three geographical preferences. So there's a map. If you just type in like ERAS, like geographical preferences, it'll give you regions, and you can select three of those. Um, would definitely look into programs that you like, and then areas of the country as well, and figure out how those fall in together. So, like kind of what I did, I looked at programs that I was thinking about applying to, and then saw which geographical regions they fell in, and then I basically did the top three regions to increase like the signal to geographical preference like rate, because you can signal a place, but if you don't geographically like preference that area, there could be like a discordance, and some place might think that that could be a problem. I don't know the exact data on it, but if you do have a geographical preference and a signal, I think you have a better shot at getting an interview.
That's actually a really good point. And I'll add to that that I'm pretty sure most programs they value the signals a lot more than the geographic preference. But when you can have all of it congruent, that helps, of course. And I would say like if you're someone who really needs to be in one area of the country, then you really need to do away rotations all in that area. Whether you have a spouse there, family, etc., you need to show that you're invested in that place. Especially if it's not where in the southeast region where MCG is. Like, or if you want to just be broadly applying, then doing your away rotations in different parts of the country might be your best bet to kind of show the program directors you're not locked in to just stay in the southeast, just stay in the northeast, etc. So that's my follow-up that I would add.
And one thing just to touch on that, sorry, Sam, interrupt, is
Yeah,
like
go ahead.
uh if you're an M1 right now and you're listening and you're like, what the hell is going on? Like, what are these people talking about? You would be me in your position. So I think this stuff is very important. It doesn't hurt to hear it early on, but if you don't fully understand what we're saying and it sounds like a different language, that's okay. It is like you'll figure this out as you get closer. But we want to touch on this stuff for those that are closer to this kind of process of applying, because this is stuff that later on is going to be important. But yeah, if you're earlier on, enjoy your time, get involved in things that we talked about, that are, that you enjoy and that you're going to be able to talk about. And if you can even, if you can have a PM&R twist to it, even better. But yeah.
Cool. And also, Michael, I think you mentioned before you had some resources, just information about all this stuff. If you could drop that in the group me after, that'd be great. And then, right now I just wanted to see if anyone else listening in had any specific questions. Open it up, or feel free to type in the chat or just mute.
I have a question. I wasn't able to join until now, but I was actually just shadowing like a PM&R doctor that was more specifically in the TBI field. So I was wondering if you guys have any interest in like a fellowship or something, if you could like speak to your experiences with that.
Yeah, so I'm pretty open. I mean, my personal interest is more like performing arts medicine slash sports medicine, but I've also been toying with the idea of also doing spinal cord injury, maybe brain injury. I think spinal cord and TBI, those are fellowships that are not as competitive to do, but I think those are some of the most intellectually and personally satisfying ones in inpatient physiatry. Because I think after a while, if you're just doing general inpatient like stroke rehab and other stuff, I've kind of found, at least from my observation, that you're not getting to do a whole lot of new diagnosis all the time, not a whole lot of new medical management. But with TBI, you have medicines like amantadine that can help kind of modulate cognitive function. And then there's so many aspects of like spasticity and other things you're also actively managing, whether it's spinal cord versus TBI, that kind of gives you some extra, that makes it a little more fun, I think. Certainly it can be very challenging, like we were kind of joking about it there. Like Brandon and I were joking about earlier about how like the neural exam on someone where they're not as participatory is challenging, but that that's another thing that can kind of add flavor, kind of add to the spice of your job in physiatry. I think it's not one of the more competitive specialties. So honestly, if you were to just go to a lot of decent PM&R programs that have some exposure to it, and you were interested in that, it would be able to set you up for success to get into the fellowship. Things you might want to look out for if that is your top interest is a residency that has a locked unit. What that means is that they have patients who've had traumatic brain injuries on a unit that's locked for really their own safety because of how much of a cognitive deficit they've had from the injury. What that means is that you get to treat people with some of the more mild to very severe injuries and really get to become an expert in treating TBI.
Yeah, no, I think that was well said by James too. And also looking at um as for especially like kind of spinal cord and TBI, they haven't been as competitive. And so going to a if like looking at programs and seeing if they have a fellowship attached, if it comes to applying to that and you have like a really strong interest in that field and you can talk about that, that's something that program is going to really take into account because they are thinking sometimes about the future down the road too. They want to make sure that their program fills as well and being able to speak to an interest like that, I think yeah. No, that's great. And it's cool to already have like have an interest like that. Because I know we talked about like you don't want to come across just as one thing, but like at the same time, I think there is something special to like having like a passion and if it like shows through I think that can really help you stand out too yeah.
Yeah, and just one or two things to add to what they just said. I also think going to a place, kind of learning about what type of equipment they have in terms of rehabilitation is nice. Because if you go to a place that has more of a state of the art, like neuro rehabilitation gym, then you can kind of um, assume that like neuro rehab is something that they're very passionate about and that they have like a lot of potential funding for and potential research in that area. So those are things to look out for, just asking about what kind of research they're doing, yeah, what the gyms look like, and then maybe like what are some of like the outpatient like day programs once the patient gets to the next point, just to see what the continuity looks like. I think are a couple of things you can also look into.
Yeah, that was a great question. Great answers. Just if anyone else has any more questions too, feel free to speak up. Drop it in the chat as well. And then, once again, we're recording this session, so definitely will be sent out that so that you guys can have, going forward and always come back to this video. Um, but yeah, just see if anyone else has any questions. If not, Brandon, James, any parting words? I guess as we're
Got a
wrapping up
quick
here.
question.
Yeah, go ahead.
Yeah, this might be a little bit of a silly question, but what are the sort of like overlaps and distinctions between, I guess, the inpatient sort of traumatic brain injury side of PM&R and like neurology?
That one's a good one. I don't know, Brandon, you want to take a stab at that?
Yeah, I can try. So I really didn't have a ton of exposure for like inpatient neurorehabilitation. I may have had, a couple of weeks for that. Um, so I guess in if you're looking in terms of more of like stroke, I'd say that you would have a neurologist managing extremely acute symptoms of the stroke while they're in the hospital. And then once the patient is stable enough, then they can be transferred um, out to be managed by PM&R from a rehab standpoint. In terms of, I guess, a TBI, I think maybe James or Michael could give some more insight just because I think I had like some of the least exposure in terms of that realm.
You want to
James,
try, Michael, or do you want
yeah,
me to?
we can tag team it
Yeah.
I'll say so like I think the way I kind of see it Brandon kind of hit on it is like acute versus what happens after. I think that's kind of the one thing I enjoyed about PM&R was, it's like what happens after that patient that when you're on your ICU rotation, that had a catastrophic, brain injury or, or is slowly emerging disorders of consciousness. This is all stuff you learn a little bit more about when you do some rotations, but like kind of what happens after they've stabilized. Like that's kind of your role.
Mm,
It's like, and then that person's integration back into society, what's that going to look like? And you're going to have a lot more time with that patient in that kind of during that rehab period. And you can even what's kind of unique too is that you can a lot of these TBI, SCI doctors will have an outpatient clinic associated with their inpatient. So actually will have it's really actually pretty cool. You can have not only just longitudinal care during the, 2 to some places. I mean, I'm trying to think if he's like someplace like Shepherd Center, they have patients there for, 3 months. But so you see them over that period. But after that, like these are oftentimes things that are going to have lifelong functional impacts. And so every year they might continue to follow up with you, whether that's for spinal cord
mm,
injury, getting supplies, whether that's, renewed for whether it's colostomy bag, um, urine catheters. Yeah. So like, and then, so the way I see it is like neurology is very much, I feel like on the kind of the making that acute initial diagnosis side of things. Not that there isn't that aspect in PM&R too, because when it comes to doing EMGs, electrodiagnostics, that's something split between neurology and PM&R. But PM&R is like, a lot of times, like I'm on my TBI service right now. I'm reading the neurology's kind of note from on the inpatient side.
mm.
I'm reading the neurosurgeon's note. Why do they decide to operate? Why do they not? Looking at other notes as well. But now it's kind of crafting, taking into, okay, how do they present? But like, where do they go from here? And
Mm.
there is probably a role in that too, like in neurology, I'm sure. But yeah, I don't know, James. Would you want to take over from there?
Yeah, I think you set up really well. And honestly, I'll probably use a different analogy to illustrate it because I know you're asking Pranav about TBI versus like with PM&R versus neurology. So I think like use an example of like someone had an acute stroke, right? Like the stroke code is going to be run by a neurologist in the ED or wherever it happens, and they're going to give the initial recs, whether you're going to do tenecteplase, you're going to do anticoagulation, whatever. And yes, like after someone's had a stroke, eventually they might follow up with the neurologist once every so often, eventually, just to make sure they're on the appropriate like antiplatelets or other regimen. But after the initial event and they get good enough for rehab, that's really where PM&R kind of steps in more. And so you're kind of managing the sequelae after the stroke or after the brain injury and trying to figure out ways to help optimize their function, whether it's cognitive status improving medicines, whether it's also like the bowel bladder and other stuff we don't traditionally think of as much but that's still kind of a sequelae of this brain injury or stroke. Um, and I've kind of seen like when I was rotating at NYU, for example, people would have like clinics for brain injury patients and spinal cord injury patients where they would just kind of follow up for concerns about the cognitive status, spasticity, and other things. And that would be usually a PM&R trained brain injury medicine doctor who is managing that more. A neurologist could do that fellowship too, honestly, and do a lot of that things. But I think a lot of times people who go into neurology, like, yes, you're doing some management, right? But I think a lot of times you're fascinated about the very complicated, like neurological kind of like diagnosis. And that's definitely more neurology strength on average than PM&R, I would say. Like we're good at like MSK kind of diagnosis in the outpatient setting, but on the inpatient setting, a lot of it is managing kind of what has already been diagnosed initially, and then just keeping an eye out for sequelae that could happen, like whether it's like pressure ulcers, a new pneumonia, etc. So if someone wants to really focus more on like the really cool diagnosis and like that you want that to be like 80, 90% of your job, then neurology might be a better fit in that case.
And one
Thank you so
last thing,
much. Oh,
yeah,
sorry, you good?
no, you're all good. You're all good. One last thing to tap on too is I think one cool thing about PM&R too is that there's a lot of opportunities. Like if you enjoy procedures, like interventional procedures, like spasticity management. Yes, you can do that in neurology, but I'd say you probably get a little bit more of that in your PM&R training.
Yeah,
And so if hands-on procedure stuff, something that kind of interests you is important to you, I think you're going to have more training in that, and I think a better ability to build that into your practice than if you go the neurology route. Would you agree, James Brandon?
I would say so, yeah, because neurology can do Botox injections for
Yeah.
spasticity too, but I think we get more training on not just on the combination of the neural musculoskeletal stuff to kind of optimize which muscles and where do you want to really inject it to relieve spasticity, along with pain procedures, corticosteroid joint injections, all that fun stuff too.
Thank you so much. That's a good answer. Thank you.
Yeah, great question, Pranav. Guess we have time for, one or two more questions. James and Brandon, both busy schedules, and we appreciate y'all taking this time, out of your schedules right now to speak with us.
I think I'm the only M3 on the call, so this might not be relevant for everybody else. But how many away rotations did y'all apply for to land at like the target three? Like, I'm not quite sure how competitive, I guess, the away rotation slots are.
That's a good question. So I only did two away rotations, but I applied to about five places. But I will say I feel like I got a little lucky because I definitely heard of people needing to apply to like 10 to 15 to get like three away rotations. I think a lot of it is for that, you kind of, if you can apply early, I think that is the biggest thing. Because a lot of these places, they will look at your application a bit, but it's usually the program coordinator or someone who's not necessarily the program director who looks at away rotations, which is different than the residency application cycle. And I think if you apply fast and early, you have a decent application together, that can give you more callbacks than if you apply a little later. But I don't know, Brandon, how many did you end up applying for?
Yeah, I think I also applied for four, ended up getting one. So, wish I had probably gotten up to, two at that time, but now three. Definitely felt like I applied at a good time. Just think I got kind of unlucky with the draw. Would say, yeah, probably applying to more would be better to try and assure that you can get that number. And I know semantically, like sending follow-up communication to maybe a program coordinator after submitting your Vislo application may not look the best. I do think sending up follow-up communication can be helpful if you're respectful and showing interest. The worst they can do is just not respond. So I think that could be something else to do to maybe try and boost your chance at a place that you would like to rotate at.
And if you have connections, if you know anyone who knows someone there, that will always help because medicine is very much like business. Who you know makes a big difference. It can really make or break things. Um, and to touch on what Brandon said, yeah, I think follow-up communication is fine. I just wouldn't send it immediately after you apply. I might wait like a week or two at least before you follow up and then try to not do it too frequently, more than once a week maximum, because you don't want to be, because they're busy too, and you don't want to be remembered for the wrong reason.
And one more thing, just to touch on that, my experience is a little bit unique because the places I ended up getting, I on a whim when I decided PM&R, so I guess it would have been if still it's after clerkships third anyway. So like it would have been like February, I guess like when your enrichment year is kind of beginning. I guess time wise, my timeline's a little weird, but um, so I had gone to AAP that year. This year it's in Puerto Rico. So like I know we talked about, yeah, sometimes it is a little bit of an investment to go to this conference, but I had a chance at this conference. It was not in Puerto Rico. We were in like Phoenix, Arizona. Not as exciting. But was able to talk with like a lot of the different tables. And AAP, I feel is a much better medical school experience than AAPM&R medical student experience. So if there's like one that's worth going, I didn't even present anything at this one. It was just like on a whim went and just happened to kind of go to a few tables and like speak to them. And then following up based on that and being able to talk about like, just like enjoy getting me to this conference. I'm happy to have now like submitted my application. And some of the programs too, you'll have like a chance to write about like or why it's like kind of like a practice personal statement is a way to look at it. But you can also put in like why that program, and some programs they will literally take um, the moment it opens, and they're all different days. It gets confusing, but the moment it opens, some places just take the first ones that come in. Other places will actually take some time to sit down and look at them. So it really just depends on the place. But um, I just put a shout out to AAP. I think it was worth it in my experience, but you don't have to do it. There's so many different ways to go about the process, but I think applying to more than you actually plan on going to is definitely the goal because sometimes it just feels random. And that's just where we're at. Yeah, I don't know. But
Yeah. All right. Well, thank you guys.
All right, so, seeing the time, kind of wanted to wind things down. James and Brandon, is it cool with y'all if I send, your emails to the PM&R group me? Is that okay with y'all? Or best form of contact for any follow-up questions?
Yeah, yeah, you can definitely put my email in the group me.
Cool.
I also my time is going to be a little bit more free than Brandon and James too, so I can give my information and maybe if that helps y'all out because y'all are actually doing like real doctor stuff, and I'm about to really not be doing much of anything. I can kind of act and like try to see if I can kind of help screen answer some questions, and then if I can't get to the answer and need some more information, I can also get that from Brandon and James. If that sounds good to y'all, just because I know y'all got your plates full. So just a thought.
Sure.
That's
Yeah.
perfect too.
That sounds good.
But
Love it.
anyways, thanks so much, guys, for talking to us tonight.
Yeah.
And
Also, sorry, Sam,
yeah,
but
keep going.
I wanted to include the Pathways in PM&R website.
Yeah.
So kind of a plug because I'm actually also on leadership for this right now. But this organization Michael mentioned briefly was started by a med student named um gosh, my brain's too dead.
I
I've been
got
up
you,
too
James. I
much.
got you. You've been doing real doctor stuff. It's
Yeah.
Hunter, right?
Hunter. Yeah, Hunter
Yeah.
Salameni. He's
Yeah.
a PGY2 at Mayo Clinic PM&R right now. Great guy. He started the whole organization. I don't know how he still has time to run it, although he has been a little more quiet recently. He's probably too busy. But he's still pretty involved. And this website has a lot of good resources, especially at the M1 level for podcasts and just learning more about the PM&R specialty. Because I think the most important part when you're in the first couple years of medical school is just keep your open mind, explore all these specialties, get a good understanding because you want to find the right path for you, and it doesn't have to be PM&R. Whatever that is, I hope you all are able to find it. But if it is PM&R, then welcome to the fold.
All right, yeah, thank you. Definitely, I'll definitely send that one in the group me as well.
And Sam, I'll follow up too and drop a few of those other links I mentioned as well in the group too. So if y'all aren't in the group me, get in the group me. We'll have some info in there. And yeah, Sam, thanks for organizing this. And Brandon James, sorry, Dr. Hodges, Dr. Manfield, thanks for taking the time out of y'all's busy days, saving lives to be here tonight.
Appreciate y'all having us.
Yes, thank you for having us. Hope this was helpful.